This is the warm-up for reproduction 16. First question, what are the defects in tetralogy of Fallot? So you have pulmonary valvular stenosis, right ventricular hypertrophy, a VSD, and an overriding aorta. The opening of the aortic valve kind of sits right over the VSD. Next, what's the defect in Epstein anomaly? So Epstein anomaly, again, is going to be seen in babies who are born to mothers taking lithium. So Epstein anomaly is that the tricuspid leaflets are displaced downward into the right ventricle, and then the right ventricle is usually hypoplastic, and there can be some tricuspid regurgitation or tricuspid stenosis. Next, which antibiotic class is known to increase the risk of tendon rupture in adults? It's the fluoroquinolones. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on genetic diseases. This one's covering autosomal recessive, lysosomal storage, and X-linked. No intro today because I'm hungry, and the sooner I get done with this video, the closer I am to a sweet, sweet sandwich. What? Rule number 3 of medicine is never miss a meal. All right, so let's get started on our autosomal recessive diseases. So this video is going to cover some of these. Many of these are actually covered in other lectures in this course, so we won't spend an exhaustive amount of time with each one. So we're really just going to be hitting this super high yield highlights, and even just some of them, not all of them. So the first one we really need to cover is cystic fibrosis. Again, an autosomal recessive defect in the CFTR gene in chromosome 7. CFTR stands for cystic fibrosis transmembrane regulator. So what does the CFTR gene code for? Well, it codes for a transmembrane protein that puts chloride from the cell into the lumen of the pancreatic ducts and into the lumen of your airways. So if you look at this transmembrane protein, it's secreting that chloride into the lumen side. So you wouldn't think that that's such a big deal, but where chloride goes, sodium is probably going to follow to balance out the charge. And then where sodium chloride goes together, water is going to follow. So normally, sodium and chloride are going into the lumen of your airways, into your pancreatic ducts, and that's going to allow for a watery, thin secretion. Well, if you can't put chloride in, the sodium's not going to follow and the water's not going to follow, so you get very thick, very viscous secretions in your airways and in your pancreatic ducts. And they get all clogged up, and that causes a lot of problems. Now, the CFTR channel actively secretes that chloride into the lungs and the GI tract, actively reabsorbs chloride from sweat. Now, as a result, patients will get recurrent pulmonary infections. And also what you need to know, Pseudomonas is famously associated with cystic fibrosis. So you're also going to see bronchiectasis. You're also going to see pancreatic insufficiency and also meconium ileus in newborns. So this is one of the earliest signs of cystic fibrosis, and this is the most common lethal genetic disease of Caucasians. So going back to this, what is meconium ileus? Well, meconium is that first stool that a baby passes, really nasty black looking stuff. And if they don't pass that first stool within, on average maybe 48 hours, that might actually indicate a problem. Cystic fibrosis is a possibility, but Hirschsprung disease is another disease that's going to be associated with meconium ileus in that newborn. Other findings include infertility in males, and this is due to another association, a bilateral absence of the vas deferens. You're also going to have fat-soluble vitamin deficiencies, and that can present as failure to thrive. Also, because you don't reabsorb chloride from sweat, patients will actually taste salty. So maybe a mom tastes salt every time she kisses her baby. So how do you diagnose this? Well, you can diagnose this with that chloride sweat test. The increased concentration of chloride ions in the sweat test is diagnostic. Now, specifically, the chloride ions are greater than 60 milliequivalents per liter. So how do we treat cystic fibrosis? Well, we don't have a lot of great treatments. We can use something like N-acetylcysteine to loosen up mucus plugs. We're not using it as much as we used to. This is an inhaled medication. It cleaves to disulfide bonds within the mucus glucoproteins. You may also recognize that N-acetylcysteine as a potential antidote to acetaminophen toxicity. Patients will need antibiotics anytime they get bronchitis or some type of lung infection. Most of the time, we don't use a lot of the fluoroquinolones in kids, but the exception here is cystic fibrosis. A lot of times, children with cystic fibrosis have to be put on a fluoroquinolone for Pseudomonas infections. Pancreatic enzyme replacement is also important because their pancreas doesn't function very well. And fat-soluble vitamin replacement is also very important in this group. All right, so now let's move on to some lysosomal storage diseases. These are always really, really tough. So what is a lysosomal storage disease? So these are rare and are generally due to a deficiency in an enzyme that is required for the metabolism of a lot of different things. Things like lipids, things like glycoproteins, things like mucopolysaccharides. So if you can't break something down, then you end up with an accumulation of something you probably don't want. And that's where we have our problem. Too much garbage or back product is building up. So let's go through these. All right, so our first lysosomal storage disease is Fabry disease. So this is an X-linked disease. Now the deficient enzyme is the alpha-galactosidase, and it leads to an accumulation of ceramide trihexoside. So the symptoms begin in early childhood, and they include pain primarily. This is due to damage of peripheral nerves. That's going to lead to some neuropathy. You're also going to get some lipid accumulation in the GI tract, and that's in those blood vessels of the GI tract, and that's going to lead to ischemia and also pain. You're also going to see some renal failure. You're going to see some hypertension and cardiomyopathy. You also get something called angiokeratomas. Those are kind of tiny but painless papules. They can appear primarily around the lower abdomen, in the buttock area, and in the groin area as well. All right, so our next disease is called Gaucher disease. Sometimes people mistakenly call it Gaucher disease, but it's Gaucher. So this is an autosomal recessive disease, and this is the most common of the lysosomal storage diseases. Now, the enzyme deficiency here is glucocerebrosidase, and patients will accumulate the glucocerebroside, which is a lipid-like substance, which can then build up in macrophages, also in the spleen, and the liver, and the kidney, and the lungs, and the brain, and the bone marrow. So a lot of different places. Patients will develop hepatosplenomegaly. They're going to have painful bony lesions. They're going to have anemia. They're going to have fatigue. They're also going to have thrombocytopenia. That's due to an enlarged spleen. Now, under the microscope, macrophages will have prominent blue cytoplasmic fibrils. Some have described these macrophages as looking like they kind of have crumpled tissue paper. The next thing we're going to talk about is Niemann-Pick disease. So this is an autosomal recessive disease again, and the deficient enzyme is sphingomyelinase. So you're going to accumulate sphingomyelin. Now again, this is a lipid-like substance. So like in Gaucher's disease, we see hepatosplenomegaly and thrombocytopenia. Niemann-Pick has a lot of accumulation in the CNS, including the cerebellum, which leads to ataxia, dysarthria, and dysphagia. Patients will have a gradual worsening of intellectual function as well. Now, a high-yield characteristic of Niemann-Pick is that cherry red spot on the macula, which is also caused by an accumulation of substrate in the cell layers of the retina around the macula. Also somewhat unique to Niemann-Pick are the foam cells. So under the microscope, we see numerous small vacuoles which give that cytoplasm kind of a foamy-looking appearance. So next, let's talk about Tay-Sachs disease. So Tay-Sachs is an autosomal recessive disease, and the deficient enzyme is hexosaminidase. Now, you're going to see an accumulation of the GM2 ganglioside here. Now, as with many of these disorders, patients will have progressive worsening of mental and physical abilities. Now, in the infantile type, symptoms begin very early in life at around 6 months. Death generally occurs at the age of 4 years. Now, there are other forms of Tay-Sachs where the onset of symptoms can be much later in life. Now, similarly to Niemann-Pick, we see the cherry red spot of the macula in Tay-Sachs. Now, it can actually be kind of difficult sometimes to differentiate Tay-Sachs from Niemann-Pick on a step 1 question. Now, one clue is that there is no hepatosplenomegaly in Tay-Sachs patients, but there is going to be that hepatosplenomegaly in patients with Niemann-Pick disease. Now let's move on to Krabbe disease, great name. So this is an autosomal recessive disease again. The deficient enzyme here is galactocerebrosidase, and you accumulate galactocerebroside. Now this disorder affects the myelin sheath, which will lead to peripheral neuropathy, seizures, optic atrophy, weakness, and developmental delay. Now symptoms begin early again at the age of maybe about 3 to 6 months and is fatal usually before the age of 2 years. Now this may not help you, but Krabbe makes me think of Zoidberg from the show Futurama. He was kind of a lobster dude from space, which makes me think of that galactic, which reminds me of the galactocerebroside. Moving on to the metachromatic leukodystrophy. So this is an autosomal recessive again. The deficient enzyme here is aryl sulfatase, and you accumulate a cerebroside sulfate. Now, similar to Krabbe, this affects myelin sheaths. Symptoms begin after the first year of life, so a little bit later here. Patients have muscle wasting, they're going to have a lot of weakness, progressive vision loss, and even dementia. Moving on to Hurler syndrome. So this is, again, autosomal recessive. Now, the deficient enzyme here is alpha-L-ironidase, and the buildup is in heparan sulfate and dermatan sulfate. Now, these patients are normal at birth, but like many of the other diseases, we see progressive deterioration. Coarse facial features is another one, hepatosplenomegaly, and intellectual disability starting at about 6 months of age. Now, these patients do not grow very well, which leads to something that resembles dwarfism. Now, because of the coarse facial features and the other characteristics, this is sometimes referred to as gargoylism, which is pretty crude and somewhat cruel to describe people like this, but that kind of gives you an idea of coarse facial features in short stature. Now, these patients will also get corneal clouding, which will lead to vision loss. Now, there are two lesser forms of Hurler syndrome, and they are called Hurler-Schei syndrome and then just Schei syndrome. So they have the same enzyme deficiency, and they tend to have a later onset of symptoms. Next, we have Hunter syndrome. So this is an X-linked one. So remember, we have two X-linked lysosomal storage diseases that we're talking about, Hunter and Fabry. Now, one way to remember this is that X marks the spot for Hunters. Now, the deficient enzyme is iduronate sulfatase, which results in an accumulation of heparan sulfate and dermatan sulfate. Now, that should look pretty familiar because it's the same substrates for Hurler syndrome, but realize that the enzyme deficiency is different from Hurler. Now, Hunter syndrome is generally speaking just a milder form of Hurler syndrome. Now, there is a later onset where the symptoms begin between the ages of 1 and 2 years, and there's no corneal clouding with this one. And these patients also tend to have more aggressive behavior as well. All right, guys, it's time to hit the high-yield characteristics that will differentiate these diseases in an episode of Game Show. Remember to yell out the answers. You may want to stop the video in between each one and write these down to review them again later because this stuff is really hard. Let's get started. First one, optic atrophy, myelin sheath involvement, galactocerebrosidase deficiency. Answer, Krabbe disease. Next, renal failure, angiokeratomas, alpha-galactosidase deficiency. The answer, Fabry disease. Next, dwarfism, corneal clouding, alpha-L-iduronidase deficiency. That's going to be Hurler syndrome. Next, we have thrombocytopenia, macrophages with cytoplasmic fibrils, glucocerebrosidase deficiency. The answer, Gaucher disease. Next, cherry red spot on the macula, no hepatosplenomegaly, hexosaminidase A deficiency. Answer, Tay-Sachs. Next, aggressive behavior, no corneal clouding, iduronate sulfatase deficiency. The answer, Hunter syndrome. Next, we have progressive vision loss and dementia, similar to Krabbe, aryl sulfatase deficiency, metachromatic leukodystrophy. Next, cherry red spot on the macula, foam cells, sphingomyelinase deficiency. The answer, Niemann-Pick disease. Okay, so now we're going to very briefly talk about some X-linked recessive disorders. So what is an X-linked recessive disorder? Well, the mutation is on the X chromosome. Therefore, even though the disorder is recessive, males who get one effective X chromosome will actually express the gene because they only have one X chromosome. Now, females will need 2 affected X chromosomes for the gene to be expressed. So the X-linked recessive disorders include a lot of things. Bruton's agammaglobulinemia, Wiskott-Aldrich syndrome, Fabry syndrome, G6PD deficiency, ocular albinism. Now realize that general albinism is actually an autosomal recessive disease, but just the ocular albinism is X-linked. Lesch-Nyhan syndrome, Duchenne and Becker muscular dystrophy, Hunter syndrome, hemophilia A and B. Now we covered a couple of these in this lecture, and then the rest are actually covered in other lectures in a lot more detail. So for this lecture, all I want you to do is remember that these are all X-linked recessive disorders, and we have a mnemonic that we're going to use for this. So it's oblivious female will give her boys her X-linked disorder. So that's for ocular albinism again, Fabry disease, Wiskott-Aldrich, G6PD deficiency, Hunter syndrome, Bruton agammaglobulinemia, hemophilia A and B, Lesch-Nyhan syndrome, and Duchenne muscular dystrophy. So you can kind of pull that all together without mnemonic there. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those on your own, and then we'll go through them together. First question, what gene is defective in cystic fibrosis? So remember, in cystic fibrosis, it's that CFTR gene, and where is it? It's on chromosome 7. Next, what is the traditional test used to diagnose cystic fibrosis? Remember, it's that sweat chloride test. So when the concentration of the chloride ion exceeds 60 milliequivalents per liter, this is diagnostic for cystic fibrosis. Next, what two diseases can present with a cherry red spot on the macula? So remember, it was Niemann-Pick and it was Tay-Sachs. Next, which lysosomal storage disease has prominent blue cytoplasmic fibrils that resemble crumpled tissue paper? Remember, that was the Gaucher disease. Next, which two lysosomal storage diseases have myelin sheath pathology leading to peripheral neuropathy? Remember, that's the Krabbe and also the metachromatic leukodystrophy diseases. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.